Dear colleagues, dear friends, welcome again to BG Dental Academy Online. This time we continue our online masterclass series that are dedicated to porcelain veneers, and this time we decided to provide you a really interesting and discussable topic about veneers preparation, different types of veneer preparation when case is coming to molar and premolar teeth. So basically we will be discussing today and showing you step-by-step techniques to prep veneers for molars and for premolars. We are ready to show you three different types of preparations. We'll do type 1, which is window prep. We will do some cusp reduction case, and we will do full occlusal coverage with a veneering of premolar tooth. This is the sequence and this is the program for today. I would like to remind you this is our 5th episode in veneer series. If you didn't see before previous series, you can find records on our webpage en.belgrade.com in webinar or online courses folder, and you may find a lot of useful information that you can implement, that you can use directly after watching of our online webinars. Okay, so just let me make this introduction really short and we will go straight to preparation phases. I wouldn't show you and explain you really deep details regarding technical aspects of preparation. I mean speed modes, different burr sets, etc., because we have a separate online masterclass about this. We will go just straight to preparation for veneers of these molar and premolar teeth. Okay, so let us assume that this is the case when patient comes for aesthetic and functional rehabilitation, and he or she would like to get her or his teeth whiter, and we would like to improve aesthetic outcome of patient's smile. We have to discuss everything with dental technician before we start the case, and because the one who is responsible for color change is our dental technician. Okay, you have to provide to your dental technician enough information to understand initial situation and also what kind of outcome you would like to achieve with your patient as the final result. And your dental technician will guide you regarding the thickness. Okay, he will say that in this case, for example, to change A3 color of patient's teeth to BL color or to A1, let's say, or B1 color, then the dental technician needs, for example, 0.5 millimeters of ceramic veneer to mask this color. Let's just pretend like this. I mean, it's not the certain numbers that I'm just explaining to you. It's just, let's say, average or something that I just imagine. Okay, and in this case, you have to give your dental technician this space. For this, we're using depth cutting burrs, and we always do wax up, we always do mock up, and then we prep teeth through the mock up. That helps us to preserve as much tooth structures as we can, because some parts of preparations will be done within mock up, within plastic, and only some parts, some areas will be exposed in tooth surface, in tooth structures, and we are not preparing tooth 0.5, for example. We prep just 0.3 within mock up and 0.2 in tooth structure, but totally you'll have this 0.5. Okay, in this masterclass we will skip mock up, we will just prep teeth through their own structures here, and I will show you in very precise details all steps of these preparations for all these three teeth. We have already inserted depth cutter. This depth cutter that I'm using is from our burr set, and exactly this one that we are using is, let me just give you a reference number of this burr, this one that has depth of 0.4. This is the depth here, the ledge here is 0.4. This is the number of the burr, so this is 0.4, and the good thing is also for this burr is the tip here is 1.5 millimeters. This tip can be utilized as depth cutter for occlusal, for example, surface. Okay, so I'm going to stage 1 of preparation. Stage 1 of preparation is when you are using high speed. You can use turbine, you can use electric, an increasing handpiece with a high speed with a lot of water, and all of your preps have to be done supra-gingival. All finish lines, considering their position in relationship with gum, will be given into the stage 2, and we will display you, and then we will explain you in details. Okay, so let me just start preparing. I'm using my depth cutter. I'm using that depth cutter for buccal surface. You see that the tooth is pretty short, so I cannot use these 3 active elements. Okay, so we can use just 2 of them on molar, on this premolar also. Maybe for this premolar I'll be able to prep for 3 active elements. So let's go. A lot of water. You go within the surface. You see, if you keep correct angle, you will be not able to go deeper. So you go within this surface. The burr has to be driven parallel to surface that you prep. This way you will get equal, or let's say adequate preparation. This premolar will be prepared. This part we will do prep, and also supra, it has to be done supra-gingival. Okay, this is important. What else? The molar tooth will be prepped for window prep. I will explain you why and in which kind of cases, what is the indication. This premolar will be prepped for partial occlusal reduction. This one will be with a full occlusal coverage. So this molar window prep, we will not do anything from occlusal surface. We will just keep these preparations from buccal surface. This premolar, we will do some partial preparation. Basically, we will do butt joint over a buccal cusp, and the technique of preparation for this partial coverage is the same as, for example, we are going to prep canine for classic veneer, when you just make grooves on incisal area and then you join these grooves with another burr. So we are not preparing anything from palatal side. We are not doing any bevel. We are not doing any chamfer or shoulder from palatal or from lingual side. We just do really classic butt joint. So the same will be done here, and it is really important for you to keep your burr straight over the tip of the cusp in order not to get a burr in occlusal surface. Don't go here. Imagine that this premolar is canine. Okay, just I will close a palatal cusp. So this is our canine, and we will prep just over tip of the cusp without inserting of our burr to the occlusal surface. Okay, so this will be done in specific way. Okay, see, I'm just working on the tip of the cusp, and that's it. I'm not prolongating my preparations towards occlusal surface. I'm not going to fissure. I'm not going to the cusp lobe here. Okay. As for this premolar, we will do everything. We are doing preparation over tips of cusps, and also we prep occlusal surface. We prep inside fissure and palatal cusp as well. Okay, so that will be full occlusal coverage. Once you make this type of preparations, you made these grooves, we have to mark everything with pencil or with marker. We have to mark these grooves, these lines. It will be easier for you to determine the depth of preparation. Okay, so we mark all these lines all these grooves, occlusal surface also, so that we will be having less problems in orientation. It will be easier for us to determine amount of our preparation. Okay. We, as I mentioned before, we're using mock-ups for preparation as well. Okay, so what I'm trying to say is that after you mark everything as you see here, I would remove mock-up. I will take some instrument like this one. This is hand scaler, and I will just take out all this mock-up, and I will be able to see where I reach tooth surface. Okay, and after that I will just take my another burr, medium grit or coarse, and I will start to join these grooves. This is the sequence. Considering the fact that we are working without mock-up, I will just continue preparing these teeth. Okay, and I would just prep molar tooth first, and then premolar, and so on. In this case, if your patient can move head more to side this way, or you will also move your microscope, you will have more details for observation. Okay, so that will be easier for you to prep. You can see much more details. It will be more ergonomic for you. So I'm having my depth cutting burr, another burr, the tapered one, this one. This is blue stripe burr or the green stripe burr, and we can join now these grooves. For window prep and for partial reduction prep, we keep 3 planes. In keeping 3 planes, we can be really conservative because we will preserve a lot of enamel. Okay, so let me just start my preparation. So here I just go to incisal plane. Let's assume this is incisal plane, and I would prepare until I need a little bit more water. In real patient case, we'll use a lot of water during this stage because the speed is pretty high, and I don't want to overheat the tooth. So we prep incisal plane, and see that I'm prolongating my burr to mesial part of the tooth. That will help to mask transition between veneer and the tooth surface. Okay, so this is the angle of incisal plane. We did preparation. Then we keep our burr parallel to the middle plane. Okay, we keep our burr parallel to middle plane until we will lose that mark in cervical area. And also see that I'm making prolongation to mesial part of the tooth. This is important because mesially you can see transition, so you have to be careful in that term. Otherwise, your patient will be not happy with your veneer case. And now finally we will move to cervical plane. I will make initial finish line really slightly visible, just a scratch, and the angle that I'm holding my burr is the same as cervical plane. And now take a look what I'm doing. I'm just moving my burr from vertical axis of the tooth, and making preparation to distal. Okay, like this. Don't do this angle, don't make this angle, otherwise you'll get undercut. So we go, and then we turn, and we make initial finish line. On distal, we have already made initial finish line from buccal, and now we move and turn our burr to mesial aspect of the tooth, making initial finish line here. And we have to move a little bit more to mesial, because we don't want to see transition. We would like to mask transition here. So window prep, first stage of window prep is done. Okay, it's done. Pretty nice. Window prep is, we in some professional communities, we used to say window prep is easy money cases, my friends. I will explain you a little bit later on the indications. So now we go for a partial reduction. Okay, this is premolar, and now we have to cut inside, not the size, sorry, the part of tip. And see how I do this? I just angulate my burr same as distal angulation of the cusp. Then I will turn my burr towards mesial aspect of the tip of the cusp, and I'm going from occlusal surface towards buccal. Okay, why I choose that angulation? Because if I will do opposite, for example, from buccal surface to grooves, accidentally I can move my burr to the occlusal surface, and I don't want. Okay, I want to keep my burr straight over tips of the cusps that we have already marked, and we will have butt joint. We would have butt joint. Just also note and notice the angle that I'm using now when I'm preparing occlusal tip of the cusp. I have slight buccal angulation. Don't do this angle. We do this angle, okay? Once we have our cusp prepped, we will continue with planes. Same as we did for molar tooth. This will be incisal plane, let's say. That will be middle plane. And there will be initial finish line and cervical preparation. So you have to keep your burr really parallel to the surface that you prep, because sometimes trying to make finish line, people made this a straight angle like you see on the screen, but it will be a mistake, because within few seconds you will get a hugest undercut in history of dentistry. So you have to keep your burr parallel to cervical area now, okay, not to the long axis of the tooth, but to the cervical area. We are doing initial finish line using less than half of the tip, way more or less, okay, just we're making scratch. Okay, and actually we're done with partial occlusal reduction case. It's a butt joint, and we will go now for first premolar, and you can see that I have prepped all the occlusal surface. I'm changing now the burr. I will use the one that we will utilize for occlusal reduction. This one will be easier to prep, palatal side. And if you want to get all benefits or all possibilities to work with microscope, with direct vision, you can ask now your patient to move chin up. Okay, chin up. You move your microscope forward and tilt your microscope towards yourself. So you will be able to see occlusal surface this way. This position for patient is not dramatic. It is not super comfortable, but it is resistible. If you put some pillow underneath the neck of your patient may stay with this position for a pretty long time. Okay, so don't worry, you will have no problems with your patient position. So I will just take now this burr and start preparing occlusal surface, palatal, all the way until you will lose grooves. Okay, then we will turn our burr towards buccal surface and do the same here. Try to make your preparations and your movements more smooth and continuous. Don't make these rough preparations, just make your movements more smoother. So you will spend less time during second stage of preparation if your preps at this step will be smooth. Okay, so now we have prepped occlusal surface and we're actually ready for buccal surface, and we can finally turn back head of our patient to more ergonomic and comfortable for patient position. But just let me take this corner out. Yeah, now we can change position of head of patient to make it more straight, chin slightly down. Okay, so we will be able to prep buccal surface with this angle. Okay, and the same burr as I used for previous teeth, this tapered, number 16, incisal plane. In this case, when you have prepped occlusal surface, full occlusal surface, the pathway of insertion for restoration will be more vertical, like crown. So in this case we have to prep a buccal surface more like crown. So basically two planes. There will be two plane preparation. So now I will put my burr parallel to bulbosity. The tip of the burr is outside. I'm not doing this angle, just parallel to bulbosity. And I will prep this area until I will remove groove, these marks, and I will be able to see initial finish line. So what is really important during this step is not to make finish line at the very beginning, because if you will concentrate your energy and your attention to finish line, you will make undercut. But we have to concentrate our energy and attention to prep bulbosity, to remove this mark, and you will get finish line automatically because of the design of the burr. Okay, now before the second stage of preparation, let me move my patient this way. Let me dry the tooth surface, and let us finally discuss indications or what kind of clinical cases we will go for certain types of preparation. Now it's more or less understandable and we can discuss. So window prep. Window prep is when you are not preparing occlusal surface. You don't do anything from occlusal surface. You just prep buccal surface, and this type of preparation is indicated when you are just changing color. Okay, that's why we call this like easy money cases. You just need to change the color, and basically these kind of preparations can be done on upper jaw, because when you do lower jaw aesthetic makeover, when patient opens mouth, you can see occlusal surface, and just imagine if you have tooth like A4 color and you are doing BL3 for example, and you will see this occlusal surface which is pretty big contrast. So window prep is more for upper jaw, for molar teeth, for premolar teeth. When you change the color, but you are not doing anything from occlusal perspective. Okay. The second step, the second type of preparation, when we just cut tips of the cusps, and you can see now the sharp ridge here, exactly where occlusal surface begins here. Okay, this is butt area, butt joint area here all the way. It's a platform. So this type of preparation can be done when you need to make tooth longer. So basically you work in aesthetic area, making tooth longer, and also you do some occlusal adjustments. For example, you integrate these premolars into group function. Okay, or when you do lower premolars, and you know that the buccal cusps of lower premolars are more functional, so you can do this type of preparations for some also occlusal rehab cases. And for sure, when you cover all the occlusal surface, these are the cases when you do full molars rehab case. For example, you have attrition, you have erosive, you have tooth wear, you have perfunction, you need to rise the bite, you need to rise VDO, and you need to do something from occlusal area, and also you need to change the color because of the aesthetics. So basically this is veneer overlay preparation. It's not the classic veneer, the veneer overlay preparation, and we can utilize this type of prep in certain clinical cases. Okay, now we're going to have stage 2, and I'm changing the burr for the red one. So previously, I remind you, we are using medium grit burrs and coarse burrs. Now I will have my burr red diamond. The most frequently used one that I work a lot in my veneer cases is this one. You can see that this number, okay, this red diamond. The tip of this burr is 0.6 millimeters. The tip is rounded, so we have to use half or less than half of the tip. But basically, if you will use half of the tip of this burr, you'll have 0.3 finish line, which is good for many dental technicians and for many ceramic restorations. Yes, by the way, I forgot to show you before red burr, before I will start preparing teeth with the red diamond, before second stage of preparation, I would need to control the depth of preparation. Did I prep enough or not enough? So for this, we are using silicone indexes. For posterior teeth, we are using classic silicone index as we use for crowns, for example. This is full coverage silicone index, occlusal, buccal, and lingual, you see. And then we cut silicone index sagittally, so you will be able to see this part of the tooth. So let me put this silicone index to my preparations. Okay, turn head of my patient this way, and we will be able to observe if the space that we create is enough for our dental technician. I would like to remind you that we used depth cutting burr 0.4. So you can take periodontal probe and you can measure. This one is 1 millimeter. You have to take the periodontal probe that is 0.5. I think it's 0. It's halfway, right? 0.5. So basically, we prepped 0.4, 0.5. It's enough. Let me take depth cutting burr, a silicone index for another tooth, which is upper premolar, the first upper premolar. Okay. Let me check here. The tip of the cusp that we have prepped, and the buccal surface. Okay, that's fine. So basically we are having pretty good preparations, enough space for dental technician. Let me just check also. Let me check just, yeah, this one. Let me check this premolar. to be confident that everything is fine. Okay, the occlusal surface and also buccal surface 0.4, 0.5. So basically stage 1 was provided pretty precisely in terms of depth preparation. That's fine. So what does that mean? And during my second stage of preparation with the red burr, I don't need to increase depth of preparation. I would need just to make my preps more smoother and more precise. Okay, so during second stage of preparation, we will increase magnification. If you work with microscope, you increase magnification. Okay, we put red diamond. We will also decrease speed. The speed will be about 50-60,000 RPM. Okay, I will also decrease water amount. And I would prep finish line. So we have now to understand how far we have to go with the finish line, the cervical finish line. And we have, let's say, 3 scenarios: supragingival, gingival level, and intracervicular. So before the gum, supragingival, we prep in non-aesthetic areas, non-aesthetic zones, palatal side, for example, or posterior teeth, when the smile line is really low and you are not able to see gum area. Gingival level we can use in anterior area, even in aesthetic zone, but if the smile line is pretty low, when patient talks, when patient smiles, when patient laughs, when patient screams, we cannot see gum level. So basically you can keep your preps at the gum level, or if you're not changing the color. And in case when your patient has pretty high smile line and you are changing the color of the teeth, in this case we have to prep to mask the transition from veneer to the tooth surface. So basically we have to prep intracervicular. We put retraction cord. Okay, it depends on the type of, it depends on biotype. Okay, but almost in all of my cases, in normal periodontium, I'm using the 000 or 00 retraction dry non-impregnated cord, just packing this cord really gently. Sometimes when my preps are really non-aggressive and the retraction cord is packed and preparation is done without anesthesia, you put retraction cord also without anesthesia and patient is okay with that. So you have to pack really gently. Okay, and then you move your finish line to the same area, to the same level as retraction cord is. Okay, in our case here, I will not use my retraction cord because you see that the gum, the sulcus here is pretty deep. But I will just prep a little bit before the gum just to show you finish lines. Okay, I will just move my finish line a little bit down, more down, but still I will keep it supragingival just for this educational purpose, for you to be able to see what actually I'm doing. Okay, so yes, a high magnification, 50-60,000 RPM, red diamond, burr number 14, tip is 0.6, half of the tip is 0.3, and I will start to make my finish line, to reposition of finish line. Okay, so we move it a little bit more water. During this stage, assistant helps us with air spray. So we move our finish line a little bit down. I'm working with half of the burr. Again, you see what happens here in the distal. I turn my burr, I turn my burr, and you can see how half of the tip is working. Let me take some more water. Okay, that's fine. So we'll do the same from cervical and meso. Turn, don't forget to turn, not this way, this way. to get your finish line done. One more time, let me just help myself with the air spray because I have some dust on the surface. And also, you know, when your assistant helps you with air, you can visualize better areas that you work with, because with water spray you have highlights and splashes, and it's pretty difficult to understand the depth of your finish line. But when there is air, everything will be easier. Also, once you finish with the finish line, if everything is correct with your finish line, what you can do is just to smooth the buccal surface. Just make it more smooth and no pressure, just gentle movement to get your buccal surface pretty smooth. Okay, so I think that we can say that we finished preparation for molar. I'm not going deeper here on the cervical area, but in the real patient case, depends on the type of smile. I also would go more here just to mask. This is important, by the way, to move more here, because you need to mask that transition, especially in case if your patient has pretty wide smile frame. And just imagine this can be visible and your patient will be unhappy with veneers that are not masking the black or dark color of teeth. Okay, so let me continue with the premolar. Let me just rinse and dry this one. Okay, fine. So we can continue with this premolar, and the same sequence. We just reposition finish line of cervical finish line a little bit more down. Is it in focus? Not really. Yeah. So let's go. Move our finish line more down. Half of the burr or less. This is important, because if you use more than half of the tip, you would make an undercut, and we don't want to make undercut. We will just need to make a really good mini chamfer preparation. From mesial also, just go a little bit deeper to mesial proximal zone to mask transition here. Okay. Make preparation really smooth. Movements have to be smooth. And now just moving your burr really gently over the buccal surface to make it smoother after this medium grid burr. And also this transition, this is the transition from prepped occlusal surface or tip of the cusp towards buccal surface. It has to be really also really smooth, because all sharp internal angles can cause problems for ceramic restorations. Okay, it's done. Premolar is easier because it is more closer to us, and also it is smaller than molar tooth. And now let's go to this one. Same thing, we will move our finish line more down. We move finish line more down, working with a half of the burr, half tip, moving preparations more distal. Pay attention to angle that I'm using now, see? Then we go to mesial, a little bit more deeper mesially because it is high aesthetic area. We don't want to get these transitions visible. Okay, now we will make this buccal surface also smooth. We will ask our patient to move chin up. Okay, or we will move our microscope forward also, because that will help us to see occlusal surface. Okay, so now we will just modify that preparation, make it really smooth with a red burr. Same with the buccal aspect. Okay, and you see the really sharp transition here is really super sharp. It has to be super smooth, not super sharp. Otherwise, you may expect cracks and problems with ceramic restoration. So that have to be really smooth. Smooth and rounded. This is important. Okay, also what I would like to see is distal and mesial transition joining this outline. This is the outline which is finish line for your dental technician. So we have to join here. Same from mesial. Okay, fine. So basically we finished step 2. Let me dry and see. Step 2 done, and we are ready for step 3, which will be disc, just to make all internal surfaces super smooth and to make our finish line perfect. Okay, so I'm changing my burrs, I'm changing hand pieces actually. We will take our contra angle one, okay, with disc, and we will make all the surfaces really smooth with disc. We put 5000 RPM for disc. I prefer to use Softflex discs by 3M, the orange ones, not the red. The red is coarse one, the second one is orange, I think. So yeah, we decrease magnification just to see this group of teeth, and I will take my disc with just a little bit of water, really little bit of water. We don't need too much. You can even switch off or just have it really little bit, 5000 RPM, and just the abrasive part of the disc is here, is internal, and just moving your disc over the surface, this transition from buccal surface and finish lines. What is important for disc is not to touch finish line. This is important, because if you will touch finish line with disc, there will be no finish line. And you know what I'm really like to work with discs is that disc removes scratches and some small micro grooves from buccal surface, and you can expect a really good surface fit of your ceramic veneer to the surface of the tooth. Okay, this is important. So basically, we are not using discs for polishing. We just make really smooth internal surface. And when you have smooth internal surface, you may get a really good surface fit of ceramic restoration, which is really, really, really important, because you know, in the thin ceramic restorations, in veneers, literally in veneers that are completely reliant on bonding, the surface fit plays more important role than fit to finish line. Okay, so you have to make a really nice internal surface to give your dental technician conditions not to use thick spacer, because if the spacer would be thick, all this space between veneer and between the tooth will be filled with composite resin, which is really thin substrate, very soft substrate, and ceramic being a rigid material, and if it is thin and if it has something soft underneath, it can break. Okay, so that's why internal surface have to be really, really smooth. Same will be with the premolar. Okay, so we move our disc gently over the surface, trying not to touch finish line. And also, you see, with this you can make transition from buccal surface to tip of the cusp that we prepped. We can make it really smooth. Also, if your, for example, if your cusp area is too much wavy or rough, you can make it more straight with disc. Okay, but afterwards you would have to refine the finish line. Okay, but we will do it later on. For this premolar, we will continue having disc with abrasive in front. We will just make smoothening here on the occlusal surface, also on the buccal surface, occlusal surface, buccal side. And that transition, you remember, this transition, as we mentioned before, has to be super smooth, and with disc we can make it happen. It's easier than with burr. Sometimes it happens. Okay, so now let me change the abrasive area of the disc internally, and then we just make some buccal surface smoothening. Again, don't touch finish line, because it will be a problem later on. If you will touch a finish line with disc, there will be no finish line. It will be difficult for dental technician to identify this finish line. But anyways, we have another step of preparation. After you finish with disc, you can go back to your increasing handpiece. Okay, and we will change this red burr number 14 for red burr number 16. Let me show you this one. We'll take this one now. Why do we change it for the bigger size? There are two reasons. The reason number one is if you want to make, for example, finish line thicker, you can do it with a thicker burr. Okay? If you would like to keep your finish line same as it was done previously, basically we make it 0.3, and you would like to keep it 0.3, you can use thicker burr, because sometimes you can get your burr number 14, the previous burr, a little bit deeper than half of the tip, and in this case you may have a small U margin, small lip margin. Okay, and with a thicker burr you can take this lip in a really easy way. Okay, we put speed 2000 on electric motor. With your increasing handpiece it will give you 10,000. So basically now we work with 10,000 RPM, no water, and we will work with pretty high magnification. Okay, working with no water, there is a sort of risk to make some overheating, but with that type of speed, which is 10,000 RPM only, it's not a big problem for pulp. And also what is important, our assistant, Okay, and our assistant helps us with air spray. So assistant works with air spray all the time you prep. But at really low speed, you may feel yourself by tactile sensitivity if your finish line is rough, if your finish line is jumping, your burr is jumping over the finish line. Okay, so that's why we use also this speed, not just not to overheat, but by having also tactile sensitivity. Okay, so let me just modify or improve finish line if it is necessary. See that I'm not working with a half of this burr, so I'm keeping my 0.3 finish line. I'm not trying to make it thicker. Working without water, you can see that you can see details. You can control all these details. And your finish line will be super smooth. Okay, we can make some adjustments here on the top. Also this transition, nice. This is really, really, really nice transition here now. Okay, that's fine. Let's see. Yeah, the window prep done. Now we go for this one. A little bit of water, just make finish line more smooth. If you have any problem, turn, don't forget, go back to missile, same. And also once you touch your tip of the cusp by disc, it's too much soft now, it's too much rounded, this part, I mean, this one. This has to be really sharp. This have to be rounded, this has to be sharp. So let's just refine. I see that I'm also making really visible transition of proximal, from proximal to occlusal. I think that I was not accurate during the preparation of first premolar, so I have some scratch here on my second one, so I can improve this one with this burr easily. Okay, and also that transition has to be fine and visible. So done. I think that we're done. Okay, and now finally first premolar. Same, absolutely everything is the same. The only thing that I would like to pay your attention would be transition from focal surface to occlusal. That transition has to be super visible and fine. Okay, so let me ask my patient to move chin up, because I would go to occlusal and I would like to get this visible, this part. Okay, all this outline is pretty nice, pretty visible, it's sharp enough. It's sharp enough, okay, here also. Basically, we provided pretty smooth preparation during the previous stages. That's why step number 3 will not take a long, will not take a lot of time. Okay, I think that we also done with that tooth as well. Okay, let me just have this view for you to show all 3 different types of preparations. So step 1 or type 1 window prep. So here is our very final thing. Just I'm drawing this just for you to show all these outlines, let's say. That will be for dental technician. Here you will have this thing which is sharp. Okay, here. And for this premolar, the first one, this is the finish line for your dental technician. I mean, this outline is the finish line for dental tech. Okay. I think it's pretty visible and also pretty understandable. I hope so. So, during this online masterclass, I showed you 3 different types of veneer preparations for molar and premolar. You can combine these different types of preparation for many clinical cases. You can do window prep on premolar, you can do occlusal reduction and veneer overlay on molar teeth. It's just about certain clinical situation, okay? I would like to remind you also that we still have our stories marathon in Instagram. So just take some nice video shots from this online masterclass and share it in your stories with some sort of creativity. You can type some interesting funny text, and we always repost that creative stories from your side, so many people will see them, your patients will see them, and your patient will understand that you keep on learning, you keep on improving, so you are doing better dentistry for patients, and patients really admire. So always share on your Instagram pages and or Facebook pages, in your social media, that you continue your education. It works with your patients, believe me, because we made a research in that media marketing tools. Okay, so another thing is for people that are watching us now live, we will meet each other in 10 minutes. After the short break, we will do Q&A live session, so you can type your questions and I will reply to them. Okay, for those who are watching us in record, thank you for watching us even in record. I'm really sorry that you are not with us live, because we can communicate, but even though we try from BG Academy side, we try to bring you and to provide you a really nice education, practical tips, practical tricks that you can use directly after our online masterclasses. We call them online masterclasses, we are not calling them webinars. Okay, and I hope you enjoy this live session. I think that I discussed and showed a lot of practical things, so now you will have a certain understanding regarding the type of preparations and techniques of preparation for premolar teeth. If you're interested more in veneer preparations, I would refer you to our webpage enbelgrad.com, where you may find our online educational platform, and you may see our records of previous online masterclasses. For those who would like to get a really next level of education, we invite you to our BG Academy offline, not online, offline, to visit our training center and to upgrade your personal skills in different up-to-date topics. See you in 10 minutes during Q&A. For rest, goodbye, and thank you for being with us. We're online, right? Online, okay. Okay, guys, hello one more time. Now is a live Q&A session, and I got some interesting questions in comments. I'm just scrolling through, and let me thank you one more time for joining us live. It's good to communicate live, because when people watch us in record, they cannot ask questions, and they cannot get straight live answers. So actually, the first question that I got here was about bruxism. I think this question was during live presentation. So guys, when we do a webinar, when we do this online session, I'm not able to read comments. So it's better to write these comments a little bit above, because if there will be a lot of comments, I will be not able to find this comment and to reply. But since we have not that many, I found the comment about bruxism. Can we indicate tabletops and veneers, but with indirect composite or feldspathic? When you have bruxist and you do full mouth rehab case with bruxist, when you manage occlusion, when you stabilize occlusion, you can do tabletop restorations, and also you can do veneer restorations for some of teeth that will be involved into this full mouth reconstruction. So it's not a contraindication. Tabletops and veneers are not contraindication for bruxism, but again, the bruxism has to be controlled after full mouth rehab treatment. Okay, considering indirect composite for bruxist, I cannot give you any reference, because personally I don't have experience by myself, and I didn't find enough data regarding indirect composite restorations and bruxism. So I cannot answer this question. Sorry. Okay, next. When we cover occlusal surface, the veneer will not break. Okay, yeah, if you cover occlusal surface, the veneer will not break. It may break if you have extreme occlusal loads, for example, or super contacts. And can we do the occlusal veneer alone and vestibular surface alone? Actually, you can. There are some clinicians, and they show some cases when they do separately veneer as the buccal surface and veneer or tabletop restoration as separate restoration for occlusal surface. So they combine two different restoration separately. But from practical point of view, I don't see any guideline for that. I think it's too much complicated to get two restorations instead of one, then to bond it. So it's up to you, but theoretically you can do that. You can. I would like to ask about impression. Balasim asking question. I would like to ask about impression technique, and is with 3D scanner better than impression? Still, there is a fight between intraoral scanning and impressions. So the accuracy of intraoral scanners nowadays really high. The only problem that I can tell you from our experience, the only problem is that when you do intraoral scanning, the accuracy is pretty good. Okay, but the problem is that you have to get real model to fit, for dental technician, to fit restorations, to check interproximal contacts, to see fit of the restorations. And most of 3D printers, they do not allow to get similar quality and precision as cast models. Okay, so this is a little bit complicated, but 3D scanners are really good things, and they will substitute, they will replace traditional impressions, but not now. Still, impressions are good options. Okay, me, I do both. I take impressions and I do intraoral scans as well. Okay, the question from Sanita: how are overlays different from veneer lays in preparation? So overlay is type of restoration when you have to cover all the occlusal surface. Okay, and veneer lay preparation is when you cover occlusal surface or you cover partially occlusal surface and you spread your preparation to buccal surface. So actually a veneer lay preparation is combination between overlay, that is only occlusal surface, or onlay, that is partially occlusal surface, and veneer, that is from buccal surface. So this is the combination of types of preparation. So this is the difference. There is no further special preparation on the occlusal proximal margins. If you're asking about type of preparation that I did for first premolar, yes, there is no particular preparations for occlusal surface, proximal occlusal surface. It's just a butt joint. It's a flat design following the anatomical curves, but it's just butt joint preparation with no, let's say, there are margins. When you cut something, it's like a table. It's like this, okay, and you have ridge, peripheral ridge, okay. So the same when you just do occlusal reduction, there is a peripheral ridge, which is finish line for dental technician. Okay, another question from Dr. Tran. Do you prefer dual cures resin cement to light cure for these restorations? Personally, I do prefer to use light cure cements or highly filled composites to cement all of my metal-free ceramic restorations. I don't like to work with dual cure cements. Balasim asking, is the webinar begin? Webinar is over. But Balasim, you can watch this webinar in record. Record will be available for 5 days. Okay, good. Another question, how would you temporize this case? In this case, it's pretty difficult to temporize, but the tip is you can do spot edge, spot bond, and then you do this Pro Temp or Luxa Temp or whatever, or bisacryl material, and it will be partially bonded to the areas that you have prepared before. So they will be partially bonded and they will be secured on the tooth surface. But it's not that easy, you are right. Okay, another question from Poon. How can you manage the cement veneer lay on the tooth that still has proximal contact with adjacent teeth? I feel it's not that easy when I try to clean excess cement on the proximal areas. Yeah, actually, this is not that easy to cement, let's say, but if you know some tips and tricks, your life will be easier. So, first of all, as I mentioned before, I don't like to work with a dual cure cements. One of the reasons why is I'm limited in time, okay? So when you use light curable materials, you put your veneer lay on the tooth surface and you have excess of material. So you just take brush and remove excess. Then you take floss, your assistant take floss. When you secure, when you press and hold your veneer lay, your assistant may take floss and just clean proximal areas when still your cement is not light cured, and then you can light cure. So this is the simple trick, pretty simple and practical trick. Another thing is, if you may still have some interproximal excess of cement, you may use metal saw, okay, the special thin saw, then you can saw through interproximal contact and clean cement from. And also you can actually cover adjacent teeth with Teflon tape. In this case, it's not easy to pass through interproximal contacts with a Teflon tape, but the trick is, before placing Teflon, you just take spatula or a flat plastic instrument between teeth, then you just retract, deattach adjacent teeth, so you may get some small space between, and then you put Teflon between, and that's it. Okay. Another question is from Ayman. Thank you for awesome masterclass. What's the minimum and maximum thickness for veneer occlusal overlay? It's a good question, by the way. It's a very interesting question. So, the minimum thickness is a controversial topic, but theoretically, the minimum thickness of ceramic that can be placed over a occlusal surface and bonded properly, and the spacer is really thin. So in that case, your thickness of occlusal ceramic may variate from 0.3 to 0.5 millimeters. But again, this information that I just mentioned is against rules and against guidelines by manufacturer of materials, ceramic materials. But biologically and biomechanically, if you bond ceramic to enamel with a really thin spacer, ceramic may act as enamel, approximately like this. Okay, so it can be pretty thin. Personally, I try to keep ceramic on a occlusal surface. When I bond it to enamel, I try to keep it from 0.5 to 1 millimeter. Okay, 1 millimeter, I feel myself more confident. 1 millimeter, I feel myself more confident. There was a question, by the way, that I didn't answer. There was a question by another participant, Carl Souza, I think this is the name of participant, because I can see only email. So how would you temporize this? Actually, I answered. Sorry. Yeah. Another question. Your occlusal prep depth is also 0304. Occlusal depth of preparation has to be corresponded to the thickness of ceramic. Let's say, if you do additive case, when you do full mass rehab, for example, and you need to rise vertical dimension, so you need to add something. Okay, so the total thickness of ceramic may be 1 millimeter or sometimes even 1.5 millimeters. But that does not mean that you have to prep same amount from tooth surface, because you add actually. So in case of aesthetic rehab, when you don't do any increasement of vertical dimension, so basically you're not adding anything, I do preparation on the occlusal surface about 1 millimeter. Okay, about 1 millimeter. Okay, next question is Manuel. Hi from greeting from Mexico, greeting from Ukraine. That's awesome to be able to communicate with people from different parts of our planet. That's awesome because of these online possibilities. So Manuel asking, how can you tell us the difference between overlay, tabletop, and onlay? Actually, I tried. let me do it one more time. So onlay is the type of preparation, as the type of restoration. Occlusal. It's occlusal restoration that covers occlusal surface, but not all the cusps. So if you will have even one cusp uncovered, that means according to international classification, this type of restoration is onlay. Okay, when you cover all occlusal surface, this type of restoration is overlay. When you do tabletop is overlay. Okay, but it's more fancy name of overlay. Tabletop or occlusal veneer or overlay are the same. Okay, they are the same. So the classic classification is inlay, okay, when you are not covering cusps, onlay when you cover some of the cusps, and overlay when you cover all the cusps. Tabletop is the type of overlay, and occlusal veneer is also type of overlay. Okay. Good. I'm sorry, but I'm afraid to read name not correctly. Leonissima, I think. Thank you, Maxime. You are the best. Thank you very much for your kind feedback. Manuel, again, another question. When do you decide to open the interproximal contact between preparation? This is a good question. When you have caries defects, you will open, okay? When you have big black triangles and your interproximal contacts are really narrow and they localized more to the occlusal surface. In this case, you can open interproximal contacts, but the type of preparation in this case will look like more like semi-crown, okay? So when you have caries defects or you have fillings, that big fillings, and when you need to resize, reshape the tooth, I think, you open interproximal contacts. If interproximal contacts are intact and you just do a static rehab or you do even full mouth rehab, but again, the interproximal contacts are intact, we can keep these interproximal contacts still intact and performed by native tooth structures. Leonissima, there is no butt joint in window preparation, just proximal and buccal margin. Exactly, you just have, let's say, cervical margin, then proximal margin, and then you have this, how do you say, like a bevel, and you get this sharp line. Actually, I draw it in the online masterclass. Later on you will be able to get record and you can go back and you see how this margin look like. And by the way, look, this is buccal surface of our tooth. This is the buccal surface, okay? But if you will move it like this, it's actually like a butt joint. Actually, it's like a butt joint because you prep like this and you have this ridge. This is butt joint. So, but it's like that, okay? It's actually butt joint. Okay, great. Carl Souza, another question. Where would you keep your finish lines if you were doing this only on the occlusal surface, especially on the functional and non-functional cusp? Where would you keep your finish lines if you were doing this only on occlusal surface? Okay, if you just do occlusal surface, now I got a question. So you don't do anything from buccal surface, if you just do occlusal surface. And it's again, it depends on the case. If you don't have any caries defects and you do full mouth rehab and you need to rise VDO and you have a lot of enamel, let's say, preserved, that will be tabletop. So same preparation as I did for upper first premolar, but without going to buccal surface. That will be butt joint, okay? If there will be caries defects like a MOD or DO or MO, I will involve this part of proximal area into my preparation. It doesn't matter for me cusp, if the cusp is functional or non-functional. I would like to keep minimum thickness of ceramic on the surface, and my strategies are based mainly on where I will bond my veneer to or onlay to enamel or to dentin, to enamel or to composite. So that makes sense, make difference. If enamel, I can keep it 1 millimeter and less in case if spacer is really thin. If I bond ceramics to dentin or to composite, I would prefer to go for 1.5 if on occlusal surface. That's important. Okay, Dimitri, hi Maxim, thanks for your webinars. Thank you, Dimitri, for your feedback. I would like to ask you about immediate dentin sealing ideas. In what scenarios do you use it, referring to veneers? How do you manage these situations? Explain a little bit, thanks in advance. Okay, so if you prep and you open dentin, you do immediate dentin sealing. This is one of the options. Actually, I'm following this philosophy. So if I prep and I expose dentin before taking impression, before step 3, yes, before step 3, I do IDS. The IDS is pretty simple. It's just simple and understandable and classic bonding protocol in dentin. If you use total edge system, you just edge dentin for 5-10 seconds, rinse dry, then you cover it with bonding agent. Then you light cure and that's it. If you use self-edge system, you are not etching, you just do your self-edge bonding over the surface of exposed dentin, and that's it. This is immediate dentin sealing. Actually, you can read article. You just Google it, IDS. Okay, you Google IDS or immediate dentin sealing by Pascal Manier, and you may find a PDF article in internet. Also, what I can mention, if you will go to our webpage, en.belograd.com, and then you go to, let me just double check because I don't remember if we rename this part of the web page or not, because we have blog on our web page, so you may find some videos, the short videos. Yeah, actually blog, blog, en.belograd.com, okay, blog, and you may find our 1 minute dental series, and there is an episode number 12, immediate dentin sealing. So you can see steps of immediate dentin sealing on our webpage. Actually, also on our YouTube channel, you may find the same. Oh, our administrator sent you already. Wow, working pretty intensive. Rajesh, do you open contacts if there is a cavity on the mesial or distal side? Yeah, yes. If there is cavity, you open proximal because you remove cavity. It's logical, okay? It's logical, but there is one tip, okay? A really interesting one. Some people, they still don't understand how does it work, but if you are not doing any occlusal rehab, let's say, you just do aesthetics, and there is a cavity, caries defect, MOD, or just DO or MO, and cavity is small, which means you have more than 2 millimeters of thickness of the walls around this cavity. You can keep this cavity as the separate restoration. Literally, you can do direct composite restoration separately, and then you can do veneer separately. So that will be combined restoration within one tooth, and they will work separately also. It's a nice, very nice approach, very conservative approach. Very conservative. Ayman, how can we get enough retention for occlusal overlaid ceramic resist occlusal forces? Ayman, we don't need retention in adhesive dentistry. This is the issue. I know that some people, maybe for you also, it's some kind of surprise, or maybe some information that is not that easy to understand and to follow. But for adhesive restorations, we don't need retention. We need micromechanical retention. We need bonding. So when you bond tabletop, you will be not able to remove it, okay? And another thing, when you do occlusal rehabs, occlusal forces on molar teeth and premolar teeth, but mainly in molar teeth, the occlusal forces have to be vertical, okay? So there is no slight occlusal force that may affect bonding. And another thing, by the way, maybe you saw a lot of cases like trauma on young patients, when really young patients, when they come with a broken teeth, with the parts of broken anterior teeth, and then you just can bond this part of this broken tooth, and they will work for many years. But imagine this, a frontal teeth, when you will have vertical and lateral occlusal surface, and bonding works actually. Sebastian, if there is a big difference of tooth color compared to restoration color, do you prefer to do crowns for the patient? I mean, in the case of full mouth rehab. Or is big color difference between tooth and restoration lingual palatal side of tooth usually no problem for your patient? Yeah, for my patients actually palatal side or lingual side is not a big problem. It's not a big problem, but it depends. In some cases, when your patient can open mouth like a crocodile and you can see all these lingual surfaces, you may go for so-called full contour veneer, or basically it's like a crown preparations. But in the rest of the cases, I can tell you 99% of my cases, I do not cover lingual surface or palatal surface. So I just do veneer lace or veneers or yes, this type of restorations. Leonissima, can you explain me please? Leonissima, I can explain to everybody, not only for you, because a lot of people are watching us. Can you explain me please, in each situation we have to cover occlusal surface or not, or just partial coverage or occlusal surface? Leonissima, I will ask you one question also. Did you followed or did you listen this online masterclass attentively or not? Because I explained that. But just to summarize, okay, when you cover occlusal surface, there are only 3 cases when you have to cover occlusal surface. First, when you do full mouth rehab case and you need this occlusal surface to redesign occlusion, to add something to increase vertical dimension of occlusion, for example. So in this case, we cover occlusal surface. Another option, you have aesthetic case and you change color of patient's teeth and you work on lower premolars, especially second lower premolar, which is short, and you can see occlusal surface when patient speaks. Okay, in this case we will cover occlusal surface because of the color change. And third option, when you have restorative case and when you have big cavity, big MOD for example, or big amalgam filling or big composite filling or in secondary caries, and when you remove these caries, okay, and you see that walls around these cavities are really thin, in this case you have to reinforce the walls, you have to reinforce the tooth, you have to do cusp reduction and cusp coverage in this case, and then you maybe change the color. So in this case you will cover occlusal surface because of the weakness of natural walls. Okay, how to avoid sensitivity after veneer bonding? Lulia. Oh, it's a tough topic. Actually, we made the previous online masterclass that you may find on our webpage again, en.belgrad.com, in online masterclasses area. It was about bonding, okay, and during that online masterclass, which was 1.5 hours or maybe 2 hours, we were discussing all bonding protocols in very precise details, and we covered also reasons of postoperative sensitivity and how to avoid this postoperative sensitivity. What I would like to mention right now is you have to follow strictly all the rules of bonding to avoid postoperative sensitivity. This is my answer. Ayman, my question has been skipped. Ayman, sorry for that, because yeah, so if you will repeat this question now, I will reply it. Can we do overlay on composite restoration after root canal treatment, so ceramic veneer be totally bonded to composite? Yes, we can. We can, and it is now scientifically and clinically proved. You can bond your ceramic over composite, but the thickness of ceramic can have to be not thinner than 1.5 millimeters. So basically when you do endodontic treatment, basically this is my approach. I do an endodontic treatment, okay? Then I do build up. I fill pulp chamber with composite, and then I spread my composite filling also over the walls, and then ceramic overlay may go over the top of the remained walls and also on composite that is inside the tooth. So basically there will be combination. It works. It works. Balasan, if you have the cavity deep adjacent to the alveolar crest, what you will do, filling then crown or the filling? If you have the cavity at the level of alveolar crest, so basically your cavity is the bone level, in this case I will do crown lengthening or orthodontic extrusion, and then I will decide to do filling or to do crown or to do overlay. My decision to do overlay, crown or filling will be based on how much tooth structures, native tooth structures, I have in this particular case. But considering the depth of the cavity, if you have it bone level, I would go for crown lengthening or orthodontic extrusion if it's possible. Dina, thank you Dr. Maxim for this nice webinar. Thank you Dina for feedback. Looking forward to participate in one of your offline courses. Always welcome. We're more than happy to host you here in BG Dental Camp. I have noticed that you prepare the occlusal surface just like flat surface with no distal and mesial inclines. There were mesial and distal inclines. I followed the inclination. They were not completely flat. There were inclination, but the wall, not distal. You said distal or mesial? Distal mesial inclines. Distal and mesial inclines. Actually, okay, this is a nice question. I think no, there was, because the problem here is that the tooth is opaque and the light source is pretty intensive from the microscope, so you may not see all the volume. But I keep native, let's say, anatomy. I create space, okay, for ceramic, equal space, and I keep anatomical surfaces of teeth. This is what we do. Okay, good. So. Dimitri, what do you think about veneers in endodontically treated teeth? Dimitri, I have a lot of cases of endodontically treated teeth with veneers. So endodontic treatment is not contraindication for veneers. The only thing is you have to evaluate the amount of quality and quantity of tooth structures to make a decision to do veneer or to do another type of restoration. This is the answer, okay? This is the answer. Okay, my friends. Okay, my friends. I think that we don't have another question, so we will finish this live Q&A session and this webinar, this online masterclass. I was really happy to help you, to be useful with all this information that we shared here. Okay, so keep in touch, my friends. Be ready for next webinar that will be maybe next month. By the way, you have to sign up for Instagram Dental Stars conference that will be in August. This event is free of charge. You may find this information on our Instagram account, or you may find this information on webpage, which is instastars.dental. This is a webpage of Insta Dental Stars. So there will be another online educational series by six speakers. Okay, follow that. Also, you may find information about our previous online masterclasses on our webpage, which is en.belograd.com. In online courses folder, you may find our previous webinars that you may watch on record. Oh wow! Okay, we have some questions. Wow! Now we have a lot of questions. Do you ever try to use occlusal veneers as anchor retainer for the bridge? No, I didn't. Is available, for example, if the only one tooth missing, patient wants dental implants, full mouth rehab. I did some how to say, adhesive Maryland bridges. I did, but I don't have nowadays. I don't have that much cases. I refer my patients for implants. Sebastian, thank you, Dr. Maxim, for a wonderful masterclass. As always, I attended all your masterclasses online. Looking forward to attend your flight course and learn from you in future. Sanita, thank you very much for being with us all the time. You are top follower, and we really appreciate this. Keep in touch. When you prepare only the cusps on premolars without the occlusal surface, where the preparation line must be on the contact point with the antagonist or not? Thank you. It depends. Actually, there are, classically there are two options: to keep occlusal contact on ceramic, or to keep it on tooth. According to conservative treatments, it doesn't matter actually nowadays. So it's up to you. It's up to you, my friends. Okay, how do we get certificate? Oh my God. Thank you for this masterclass. I love your work. Maya. My God, I'm really sorry if I read your name not correctly. Please, my friends, my colleagues, my dear colleagues, read attentively all these messages that my staff sending you within chat, and you may find information that you can find certificate button here under this video. There will be button certificate. So you will get this certificate under comments. So if you will scroll all the comments down, right, under the comments, so you have to scroll down all the comments here, and that will be button certificate, right? It will be button certificate, so you click and you will get your certificate. So that's it. You will reload your page, you will refresh your page in your browser, and then you scroll all the comments down, and you will find this button certificates, and you get your certificate. This is the option. This is the option. But read please instructions that our people send you. Read instructions. We build up this online platform to make your life really, really easy, and but you have to be attentive in reading comments. Okay, guys, thank you very much one more time for being with us all this time, following us, and keep in touch for new events, upcoming events, and we will prepare for you some interesting topics in the nearest future. Bye-bye.